Hello students, welcome to this session Hematology basic requirement. So now first, what is hematology? Hematology is study of blood. Hem is blood and logy is study. So today we are going to study what are the things required to start the hematology laboratory and investigations.
Hello students, today we are going to study blood composition and functions. So definition of blood. Blood is a liquid connective tissue in which intercellular substance called plasma and cells like RBC, WBC and platelets are suspended. The physical characteristics of blood. So blood is red in color, pH is slightly alkaline, that is 7.2, specific gravity is 1.055 to 1.060. Blood volume in adult human body is roughly 5 liters and viscosity 5 times more than the water. So this is viscous because of the cells present in blood, that is WBC, RBC and platelets. So composition of blood, it is mainly of two things. The liquid portion is called as plasma and the solid portion is called as cells. So cells are of three types: RBC, platelets and WBC. So red blood corpuscles, platelets also called as RBC also called as erythrocytes, platelets are also called as thrombocytes, and white blood cells also called as leukocytes. Again, white blood cells are divided into two types according to the presence of granules in the cytoplasm. So if granules are absent, they are called as agranulocytes, and they are of two types, lymphocytes and monocytes. And if granules are present, they are called as granulocytes, and according to the color of the granules we can differentiate these cells. So pink color granules seen in neutrophils, orange color granules seen in eosinophils, and dark bluish color granules seen in basophils. Then plasma. So liquid portion is called as plasma and it mainly contains water, 80 to 90% water, and then biochemical substances like organic and inorganic. So organic like glucose, fatty acid, amino acid, proteins. So these are all organic compounds, and inorganic like sodium, potassium, chloride, calcium, phosphorus, iodine, iron, magnesium. So these are all inorganic compounds. So these form the biochemicals which are present in plasma. Now we will see functions of blood. So main function of blood is nutritive in nature. So it is blood supplies glucose, amino acids, vitamins from the digestive system to all over the parts of the body through the blood. Then excretory function. So it excretes urea, uric acid and unwanted substances and water from the kidney. So it is excretory function, and the main function is respiratory function. So blood carries oxygen from lungs to tissues and carbon dioxide from tissues to lungs by hemoglobin. So hemoglobin combines with oxygen, forms oxyhemoglobin, and then it gives oxygenation to the tissues. And carboxyhemoglobin by combination of hemoglobin and carbon dioxide, and then it is going to lungs and then it is exhaled outside in the environment. Then defense function by WBCs, then acid base balance, regulation of body temperature, maintenance of viscosity, then water balance. Clotting of blood is because of the platelets, maintain colloid pressure and hormone transport. So the hormones produced by endocrine glands like thyroid gland produces T3, T4 and other hormones. So these are transported to all over the body through blood, and then the homeostasis, that is balance is maintained.
Hello students, today we will have blood collection procedure lecture. So blood collections are of three types: venous, capillary and arterial. So first we will see things required for blood collection. So what should be there in your blood collection kit? So there should be syringes of different sizes like 2 ml, 5 ml, 10 ml, needle of different sizes like 24, 22, 21 and 20 number, spirit, cotton swab, bulbs like EDTA for CVC, plain for all biochemistry and serology, fluoride for blood sugar level, citrate bulb for blood coagulation testings, tourniquet and sticking for the vein to become prominent, and then for the last sticking for the pressure. So first So first is sight. So it is median cephalic vein of the forearm, or the whichever palpable, visible, prominent vein we can select of the arm, forearm, or from any wrist. Then select the vein and then clean it with spirit swab, and then apply tourniquet to make the vein prominent, and ask the patient to close the fist so that vein will become prominent, visible, and then with left hand steady the vein and then put needle into the skin and then puncture the vein, and then collect the blood. Plunger is pulled back gently when blood starts flowing into the syringe. Then remove tourniquet, collect adequate amount of the blood, and then ask the patient to open the fist and then remove needle, syringe, put pressure with spirit swab at the puncture site, and then put your collected blood into the appropriate container. Then you have to put pressure for 10 to 15 minutes to avoid the complication like hematoma. Hematoma is the seepage of blood in the subcutaneous tissue. So uses of venous blood. So all hematological investigations. So preferably venous blood we require mainly for the very large quantity of blood is required. So like hematological investigations like ESR, PCV and other cell counts. Biochemical investigations where the serum is required. Serological investigations where the serum is required, and for blood culture. So second method for blood collection is capillary method. It is also called as prick method or skin puncture method. So site in mainly adults it is ball of the left ring finger or lobe of the ear. In infants it is ball of the thumb, great toe or heel. Procedure: so first you have to clean the part with the spirit swab, and then you have to take lancet or needle and then prick that area with help of lancet or needle, and then first few drops you have to wipe out because it contains tissue fluid, and then remaining blood is collected and then investigations done. So here you can see this third method. It is arterial blood collection method. So in that radial artery is preferred, and then that is felt with 3 fingers at the radial side of the wrist joint below thumb, and then where the radius bone is there, then clean that area and then puncture the needle, puncture the site with needle attached to syringe, and then blood will come into the syringe, and then adequate quantity of the blood is withdrawn, and then apply pressure for 10 to 15 minutes with spirit swab. Uses of arterial blood: so usually it is required for blood gas analysis, and then it is done in patients of ICU patients. And uses of capillary blood: it is bleeding time, clotting time, hemoglobin, blood grouping, malarial parasite, total WBC count, differential count, RBC platelet retic count, peripheral blood smear report. So mainly capillary blood is required where the less quantity of blood is there. Thank you. Thank you. So today we will see lecture on anticoagulant. So definition: anticoagulants are chemical substances which required to prevent clotting of the blood when it is mixed with the blood in proper proportion. So in short we will see clotting mechanism. So when there is an injury to the vessel, so in first step the thromboplastin is released, and then that is activated. Then in second step it activates prothrombin into thrombin, and then it activates the fibrinogen into fibrin monomer, and then all fibrin monomer combine to form fibrin polymer, in which all the WBCs, platelets get entangled, and then it forms the clot, and then it covers that injury area, and so that bleeding stops. Now we will see a few examples of anticoagulants. So first is ideal anticoagulant used in hematology. It is EDTA, ethylene diamine tetraacetic acid. So mechanism mainly it is calcium chelating agent. So it removes calcium, and so that there is no clotting, and then blood is in liquid state. So uses of is all hematological investigations like HB, CBC, ESR, PCV, and all cell counts. Second is trisodium citrate. It is 3.8 to 3.2%. Mechanism mainly it converts ionized calcium into unionized and because of that then they are not available for the blood clotting. Uses mainly by ESR by Weissengreen method and prothrombin time or blood coagulation tests like PT, PTT, APTT, etc. Third is sodium fluoride. So mechanism mainly it is prevent glycolysis of the sugar in the blood, and because of that the blood sugar level is maintained, because it prevents action of enzyme glucose oxidase, and uses is blood sugar level. Other anticoagulants. First is heparin. Action is antithrombin and use mainly it is for the blood gas analysis. Next is blood that is double oxalate. It is ammonium oxalate plus potassium oxalate, and then uses are like EDTA. The potassium oxalate it is mainly used for the blood urea level. Plain bulb where the no anticoagulant is added, and it is mainly required for the serum preparation, which is required for the biochemical and serological investigations. Anticoagulants used in blood bank. So first it was ACD, that is acid citrate dextrose. Then it was CPD, that is citrate phosphate dextrose, and now it is used is CPDA, that is citrate phosphate dextrose adenine, or sometimes SAGM, that is saline adenine glucose mannitol. So we will see functions of each component. So citrate it acts as a anticoagulant. Phosphate it acts as a buffer. Dextrose it gives nourishment to the RBCs to be kept for more days, and mannitol it is a membrane RBC membrane stabilizing agent. So ACD blood can be stored up to 21 days. CPD blood can be stored up to 30 days. CPDA blood can be stored up to 35 days, and SAGM blood can be stored up to 42 days, and this SAGM mainly used in a high setup blood banks. Hello students, today we will talk liquid portion separated from blood after clotting. So in that anticoagulant is not added, and because of that clotting mechanism takes place. Plasma is liquid portion separated without anticoagulant, and therefore clotting mechanism doesn't take place. So clotting factors are not present in serum, but clotting factors are present in plasma. Serum is used for preparation mainly for the investigations of biochemistry or serology, and then in that plain bulb you have to use for collection of the blood. Plasma is used mainly for the blood coagulation test like PT, PTT, APTT, or blood sugar test like fluoride bulb is used, and for blood coagulation test citrate bulb is used. Thank you. Hello students, today we will see about hemoglobin.
So it is conjugated protein which consists of heme and globin, and it is present in RBC which gives red color to the blood. The functions of hemoglobin to carry oxygen from lungs to tissues and to carry carbon dioxide away from tissues to lungs, and then it is exhaled out. And it also helps in acid-base balance. So respiratory function and acid-base balance. The normal range of hemoglobin in males it is 14 to 18 gram %, and in females it is 11.5 to 14.5 gram %. The clinical significance, hemoglobin value is low when there is a hemodilution, that means it is seen in anemia or pregnancy. Hemoglobin high value is seen in hemoconcentration, that is because of the dehydration, can be because of diarrhea, vomiting, or increased RBC count, polycythemia, or congenital heart disease, chronic lung disease. So in these conditions we will see high hemoglobin value. The first parameter from the CBC is hemoglobin. The hemoglobin is heme plus globin, and the heme contains iron plus porphyrin rings, and globin contains 4 polypeptide chains, that is 2 alpha and 2 beta. And because the abnormality in alpha and beta chain, we can see conditions like sickle cell anemia, thalassemia. The normal range of hemoglobin in adult female is 11 to 14 gram %, and in adult male it is 14 to 18 gram %. If the value of the hemoglobin is lower than the normal range, then it is called as anemia. It is seen in iron deficiency anemia, vitamin B12 deficiency anemia. Because of the deficiency of vitamin B12 or folic acid, it may cause megaloblastic anemia. It can be seen in pregnancy because of the hemodilution. If the hemoglobin concentration is high, hemoconcentration, then it can be seen because of the body fluid loss, that is diarrhea, vomiting or high fever. It can be seen if the cell concentration is more, that is polycythemia, congenital heart disease, chronic lung disease.
So definition, it is conjugated protein, that is it is mixed protein synthesized in RBC, and it is of two components, heme and globin, and because of that it gives red color to the RBC or blood. Structure, it composed of heme and globin. Heme is composed of iron plus protoporphyrin, and globin is composed of 4 polypeptide chains, 2 alpha and 2 beta. Function of hemoglobin is to carry oxygen from lungs to tissues, to carry carbon dioxide from tissues to lungs, and acid base balance or buffer. Types of hemoglobin, they are different, like oxyhemoglobin, carboxyhemoglobin, sulfhemoglobin, methemoglobin, or abnormal hemoglobins like HbS, which is seen in sickle cell anemia, HbF, which is seen in thalassemia, that is fetal hemoglobin. Normal range of hemoglobin in males it is 14 to 18 gram per cent, and in females it is 11.5 to 14.5 gram per cent. In liver, here you can see this cycle. So in liver, this protoporphyrin forms, which is of 4 protoporphyral rings. It is combined with glucuronic acid and forms conjugated bilirubin. Then from this it will go to the small intestine, that is duodenum, from the bile duct, and then it will go to the large intestine, and where because of the bacterial action it is converted into the stercobilinogen, and then it is excreted into the stool. Some part of the conjugated bilirubin will go to the kidney through circulation, and then it is converted into urobilinogen and it is excreted in the urine. So this all the hemoglobin metabolism, that is breaking down of the hemoglobin, and then excreted unwanted part of the hemoglobin, that is by pigments, that is stercobilinogen and urobilinogen. Thank you.
Hello students, let's study about blood cells, that is RBCs, WBCs and platelets. RBC, also called as erythrocytes, that is red blood cells. They are anucleated biconcave cells, and normally in male they are 4.5 to 6 million cells, and in female 4 to 4.5 million cells per cubic millimeter. If the RBC count is increased than the normal range, it is called as erythrocytosis. It is seen in hemoconcentration due to diarrhea or vomiting, burns, cholera, high fever, exercise. In cyanotic states like chronic heart disease, in polycythemia also we can see erythrocytosis. If the normal range of the RBC count is low, it is called as erythrocytopenia. It is seen normally in old age, pregnancy, anemia, pancytopenia. Reticulocyte, it is an immature RBC which is developed from the late normoblast, and then it continues to develop into the RBCs. So the cell size is around 7.5 to 8 micron, nucleus absent, but cytoplasm contains hemoglobin in large quantity with little RNA, ribonucleic acid. Normal range of reticulocyte in adults is 0.2 to 2%, in infants it is 2 to 6%. Reticulocyte count is increase is called as reticulocytosis. It is seen in hemolytic anemia, acute blood loss, hemolytic disease of newborn, thalassemia, iron deficiency anemia. And absence or low count of reticulocytes is seen in bone marrow suppression, that is aplastic anemia. The next parameter from the CBC is leukocytes, also called as white blood cells or corpuscles, and they are nucleated corpuscles, and based on the morphology they are divided into granulocytes, which consist of neutrophil, eosinophil, basophil, and agranulocytes, that is granules absent in the cytoplasm, and they are of two types, lymphocytes and monocytes. The normal range in adult it is 4000 to 10,000 cells per cubic millimeter, and in newborn baby it may be 10,000 to 25,000 cells per cubic millimeter. If the WBC count is increased, it is called as leukocytosis, and it is seen in infections like bacteria, virus, protozoa or fungal infection. If the WBC count is less than the 4000 cells per cubic millimeter, it is called as leukopenia. It is seen in typhoid fever, tuberculosis, influenza, AIDS, dengue, falciparum, malaria. So chronic conditions you can see leukopenia, and acute condition you can see leukocytosis. So fifth parameter from the CBC is differential leukocyte count. So in that, granulocytes, that is the granules seen in the cytoplasm, so they are of three types: neutrophil, eosinophil and basophil. So neutrophils are usually for 10 to 14 micron in size, and the cytoplasm contains fine pink color granules, and nucleus has the 2 to 3 lobes. Eosinophil, it is usually bilobed, and the cytoplasm contains orange coarse, that is bigger granules. Basophil, the nucleus is either bi or trilobed, but the cytoplasm contains plenty of the bluish black color granules. Then agranulocyte, so first is lymphocyte, so it is round nucleus with round cell with slight bluish cytoplasm without granules. And monocyte, the nucleus is kidney shaped, and it is biggest cell, that is 14 to 22 micron in size, and the cytoplasm is grayish blue color without granules. Now we can see pathological leukocytosis because of the neutrophilia, that is increase in neutrophil count, and it is seen mainly in infective condition, that is infection due to bacteria, virus or parasites. Then inflammatory condition like rheumatoid arthritis, acute rheumatic fever, myocardial infarction, or because of the operation, fracture, and can be seen in if the count is raised more than 70 to 80,000 or 1 lakh, it is called as leukemia. Then lymphocytosis, it is increased lymphocyte count. It is mainly seen in viral infection like mumps, measles, influenza, rubella, and some bacterial infection like typhoid, tuberculosis, syphilis. Eosinophilia, it is increased eosinophil count, and it is due to allergy to dust, drugs, or asthma, hay fever, or parasitic infection. Monocytosis, it is increased monocyte count. It is usually seen in viral infection like infectious mononucleosis, then malaria, typhoid, kala azar. Basophilia, it is increased basophil count. It is seen in chronic myeloid leukemia. When the WBC count is less than 4000 cells per cubic millimeter, it may be due to neutropenia, that is decreased neutrophil count, and it is seen in bacterial infection like typhoid, viral infection like measles, influenza, in anemia like aplastic anemia, megaloblastic iron deficiency anemia, or bone marrow depression because of the chemotherapy, radiotherapy. Then lymphocytopenia because of the viral infection or typhoid or excess radiotherapy or leukemia, AIDS, anemia, pancytopenia, you can see lymphopenia. Absolute eosinophil count, so they are eosinophils total in count present in blood per microliter. So the normally they are 40 to 450 per cubic millimeter. The clinically, if they are increased, they are seen in parasitic infection, allergic reaction, and some leukemias. And decreased eosinophil count is seen in increased adrenal function. The next parameter is total platelet count. They are 2 to 3 micron size platelets seen in blood, and normally they are 2.5 to 5 lakh cells per cubic millimeter. In clinically, the platelet count is important for the investigation of bleeding disorders, and if the platelet count is decreased, it is called as thrombocytopenia, and it is associated with the prolonged bleeding. It is seen in aplastic anemia, megaloblastic anemia, acute leukemia, dengue fever, falciparum malaria. If they increase platelet count, it is called as thrombocytosis, and it is seen mainly in splenectomy patient, that is removal of the spleen, and in chronic myelogenous leukemia. So peripheral blood smear, first is the sample collection. So it is a simple and gold standard confirmatory test for the malaria, and filaria or other blood parasites. So specimen, the collected peripheral blood from the earlobe or by finger prick or great toe in the infants. The time of taking blood should be collected few hours after the height of the paroxysm of the fever and before taking antimalarial or antifilarial drugs. Frequency, smears should be examined at least twice daily until parasites are detected. The types of the blood smears, there are two types, thin blood smear and thick blood smear. So you can see in this picture. So the observation in thick and thin smear, so usually in thick blood film you can see only the imprints of the parasites, that is the ring form blue in color and the nucleus is pink in color, and very few RBCs you can see. And thin blood smear you can see plenty of RBCs containing the ring form of the parasites, that is thin nucleus is pink in color and the ring is blue in color. Now we will see difference between thick and thin smear. So usually thick smear is used for the screening purpose and thin smear is used for the identification of the species by different morphological forms. So thick smear, the advantages, it is more sensitive. When only 5 to 10 parasites per microliter of blood is there, you can see the parasites. And the quantification of the parasite, that is parasitic index, you can make out from the thick smear. And demonstrating malarial pigments like Schaffner's dots, Zeeman pigments in the different species of the malaria. The disadvantage of the thick smear, the species identification is not possible. The thin smear advantages, the species identification of the malaria is possible because of the different morphological forms, that is ring form, tropozoite, seizoid, gametocyte form of the species. The disadvantages, it has the low sensitivity, so you need more than 200 parasites per microliter of the blood to see the parasites. So these are different morphological forms of the parasites of the Plasmodium vivax. So first A shows ring form of the Plasmodium vivax. The ring is thick blue in color and the nucleus is pink in color. Then you can see the RBCs containing Schaffner's dots, that is pink color dots, and the amoeboid tropozoite of the P vivax, that is blue in color and the nucleus pink in color. Then you can see seizoid form in the C, that is many merozoites are there in the regular round structure, that is seizoid form. Then you can see male gametocyte and female gametocyte form of the Plasmodium vivax. Now you can see in A, that is Plasmodium falciparum morphological form. So in A you can see ring forms. So there are few RBCs containing multiple rings, few RBCs containing the headphone appearance of the ring form of the Plasmodium falciparum, or you can see a cold form. Then in B you can see banana shaped B and C you can see banana shaped gametocytes of the Plasmodium falciparum. So only two forms are seen in Plasmodium falciparum. Seizoid and tropozoite are usually not seen in peripheral blood. Then in D you can see ring form of the Plasmodium ovale. So RBC is oval in shape, so you can, because of that the name is Plasmodium ovale. And in E you can see band form tropozoite of the Plasmodium malariae. So uses of the peripheral blood smear for the blood parasites. So first is Plasmodium species, then Trypanosoma, then Leishmania, you can see LD bodies, then Wucheria bancrofti. So microfilarial forms you can see in the slide. So these are different parasites you can detect into the PBS. Uses of peripheral blood smear. So reporting can be done. First is RBC morphology. So we can see size, shape and inclusions present in the RBCs. So here few examples. So in size variation can be bigger RBCs, macrocytes, smaller RBC microcytes, oval macrocytes, or according to the color of the RBCs, it is hypochromasia if it is pale in color. If it is purple in color, then it is polychromasia, or hyperchromasia if they are spirocytes. Then different shapes, it can be target cell, teardrop cell, oval cells, elliptocytes, tomatocytes, pencil shape, sickle shape, burr cell. So these are different shapes. And inclusions, some basophilic stippling can be present, purple granules inside the RBCs, ring form that is called cabot ring, hinge bodies, So the Hoyle Jolly body is seen in megaloblastic anemia. So these are different RBC morphology we can see. Then WBC we can report as total count, whether it is normal, increase or decrease. Differential count, whether it is lymphocytosis, neutrophilia or eosinocytophilia. Then abnormal cells, any atypical cells, blast cells or other abnormal cells. Platelet count can be normal or abnormal. And then morphology, so normal in size or bigger in size. Then parasites like plasmodium, filaria, leishmania, different morphological forms, ring form, tropozoid form, gametocyte form, season form, or in filaria, microfilaria, we can see. So this is reporting of a PBS. So to summarize the uses of CBC, that is complete blood cell count. So hemoglobin helps to know the anemia and which type of anemia can be sickle cell anemia, thalassemia, megaloblastic anemia, iron deficiency anemia. Then total RBC count helps in knowing the anemia, polycythemia, and then RBC different morphologies. Then total leukocyte count and differential leukocyte count helps to know the infection, inflammation, leukemoid reaction, multiple myeloma or leukemia. Platelet count helps in bleeding disorders like dengue or falciparum malaria. Then RBC indices helps for the morphological classification of anemia, whether microcytic or macrocytic. If microcytic, it can be seen in iron deficiency anemia, sickle cell anemia, thalassemia. Macrocytic can be seen in megaloblastic anemia, hemolytic anemia. Then RDW, that is red cell diameter width, is important parameter, can be calculated only by the automated cell machine, and if it is increased, it is seen in anisocytosis, that is thalassemia, in that it is normal. So these are the uses of the complete blood cell count.
Hello students, today we will see about erythrocyte sedimentation rate, that is ESR. So definition: when anticoagulated blood is allowed to stand undisturbed for a period of time, that is 1 hour, then RBCs sink to the bottom, and then two layers are formed. Upper layer, that is liquid portion, is called as plasma, and the lower layer is of red blood cells, that is red in color. So the rate at which the cells fall down is called as ESR, or erythrocyte sedimentation rate. So sedimentation means sedimenting down or falling down. So ESR is of prognostic value, not a diagnostic value. So stages are 3 stages. First, aggregation, so cell come together, then formation of rouleaux, that is they pile on each other in form of coin, and then sedimentation, that is falling of the RBCs.
So the sixth parameter from the CBC is RBC indices, also called as Winthrop's constant, and these are very important for the morphological classification of anemia. So first is for that we should know PCV, that is hematocrit. It is packed cell volume, and it can be done by the Winthrop's method manually, and in automated cell counter you can get the reading automatically by calculation. So normal range is in male it is 42 to 52%, and in female 36 to 48%. If the PCV is decreased, it is seen in anemia. Then it is increased, it is seen in polycythemia, or conditions in water loss is there, that is dehydration, and sometimes it is seen in lung disease, heart disease. So you can see in this picture the bottom are the erythrocytes, in between plasma and erythrocytes it is buffy coat, and it is mostly consist of leukocytes and platelets, and buffy coat is important. If the WBC count is less than 4000, then differential count can be done by examination of the buffy coat. So in erythrocyte indices, MCV, mean corpuscular volume, MCH, mean corpuscular hemoglobin, MCHC, mean corpuscular hemoglobin concentration, and color index. So these are the three mainly, MCV, MCH, MCHC are the erythrocyte indices. So normally MCV is 82 to 92 femtometer, and increased MCV can be seen in macrocytosis, that is megaloblastic anemia. MCH is 27 to 32 picogram, and increased MCH is seen in macrocytosis, and decreased MCH is seen in hypochromia. So can be seen in conditions like iron deficiency anemia, thalassemia, sickle cell anemia. MCHC, it is 32 to 36%, and it is seen increase in spirocytosis and decrease in hypochromia. The color index, it is hemoglobin percentage divided by the RBC percentage, and the normal range is 0.85 to 1.15. It is increase in megaloblastic anemia and decrease in hypochromia.
Hello students, today we will see hemopoiesis. So hem means blood, poiesis means production. So hemopoiesis, it is development and maturation of the cells, that is RBC, WBC and platelets in marrow, bone marrow. It is called as hemopoiesis. There are three types. Erythropoiesis, it is development and maturation of RBC. Leukopoiesis, it is development and maturation of WBC. And thrombopoiesis, it is development and maturation of platelets. So in erythropoiesis, it takes place usually in bone marrow. So first cell is hemocytoblast. So this is most precursor cell. It is most larger in size, round cell with nucleoli, bluish purple color cytoplasm and nucleoli present in the nucleus. Then it develops into the pronormoblast, then early normoblast. It is basophilic, that is purple in color. Then intermediate normoblast, it is polychromatic, that is cytoplasm is purple and pink in color. Then late normoblast, it is around 7 to 10 micron in size. Nucleus is eccentric, nucleoli absent and cytoplasm pink in color. Then the nucleus breaks down and then it is formed, that is reticulocyte. This is immature stage of RBC. Nucleus absent but nucleus present in the cytoplasm in network of the basophilic ribonucleoprotein. It is called reticulocyte. And then finally the mature RBC develops, that is 7.2 micron in size, nucleus absent and cytoplasm is uniformly red with the central pallor. So in this diagram you can see all the stages of the erythropoiesis. Thrombopoiesis, it is maturation and development of the platelets from the precursor cell, that is hemocytoblast. Then it develops into the megakaryoblast, which is 20 to 25 micron in size, then promegakaryocyte and then megakaryocyte. It is 10 to 14 micron in size. It is irregular in shape, nucleus in form of many lobes, nucleoli absent, cytoplasm pale blue and granules purple blue in color. And then from megakaryocyte platelets develop. It is also called as thrombocyte and the size of platelet is 2 to 3 micron, non-nucleated, round to oval bodies. Cytoplasm is blue or purple and platelets are formed by nipping of the pseudopodia of the megakaryocyte. And the significance of megakaryocyte, if it is increase in bone marrow cells, then it may be the condition like thrombocytopenia or idiopathic thrombocytopenic purpura. Leukopoiesis, it is maturation and development of the leukocytes, that is all the cells like neutrophil, eosinophil, basophil, then lymphocyte and monocyte. So it is usually seen in bone marrow, lymphoid series seen in lymph nodes and monocyte in spleen and bone marrow. The stages are, the first stage is hemocytoblast, that is common stem cell. It is larger in size. Then it develops into the, matures into the myeloblast. It is 10 to 18 micron oval, big nucleus with nucleoli and cytoplasm is usually light blue, no granules. Then promyelocyte, it is differentiated into neutrophilic, eosinophilic or basophilic according to the granules present, either pink, orange or bluish black in color respectively. Then it matures into the myelocyte, which is smaller in size. Then eccentric oval nucleus is present and then no nucleoli, granules in cytoplasm are present. Then it develops into the metamyelocyte. The nucleus is kidney shaped, cytoplasm granules present, and then it develops into the band form in which nucleus is in band shape, and then finally segmented nucleus of 2 to 3 lobes nucleus is developed. So this is all about the neutrophil or eosinophil or basophilic leukopoiesis. Then lymphoid series, it is hemocytoblast, develops into the lymphoblast and then finally mature lymphocyte. So lymphoblast is round with the bluish cytoplasm and nucleus which contains nucleoli. Then monocyte series, hemocytoblast, monoblast, it is size of 10 to 14 to 20 micron. Nucleus is oval or kidney shape. Nucleoli present in the nucleus, and cytoplasm is bluish gray. And then finally monocyte, that is nucleus kidney shape, nucleoli absent in monocyte is produced. In this diagram you can see all the stages of the developments, like in neutrophil it is neutrophilic myeloblast, then promyelocyte, myelocyte, metamyelocyte, band form, and finally segmented neutrophil. And according to the color differentiation in the cytoplasm, you can differentiate pink color neutrophilic, orange color eosinophilic, and bluish black color that is basophilic. So hemopoiesis, if it is seen normally in bone marrow, or lymphoid series in lymph nodes, and monocyte series in bone marrow or spleen, then it is called as medullary hemopoiesis. And in pathological condition, if the hemopoiesis seen in other organs like spleen, lymph node, then it is called as extramedullary hemopoiesis.
Structure of bone marrow. Red marrow present between bony trabecula, which contains cells of myeloid, lymphoid, erythroid and thrombopoietic series, and reticulum fibers, blood vessels and fat cells. The examination of cellular composition of bone marrow is essential for diagnostic purpose in wide variety of disorders of the hemopoietic system. The types of bone marrow are bone marrow aspiration and Triffin biopsy. Bone marrow aspiration, it is aspiration of particles of bone marrow with help of aspiration needles. The needles should be strong, wide bore, and it should be with the guard to prevent over penetration. The examples of bone marrow aspiration needles are Klima, Salah, Jamshidi. The sites of bone aspiration collection is in adults, body of the sternum or iliac crest. In children, if it is less than 1 year, then it is medial aspect of the tibia, and for more than 1 year child, it is iliac crest. Now we will see procedure of bone marrow aspiration. So in that, first local anesthesia is given into the periosteum, or sedation or general anesthesia is given in children. Then clean the parts, like if you are taking for adults the body of the sternum, or for the child medial aspect of the tibia or iliac crest, then clean the parts with aseptic precaution with spirit and betadine. Then bone marrow aspiration needle is introduced into the bony cavity by to and fro movement. After cavity is penetrated, stellate is withdrawn and tightly fitting syringe is attached. Then brief and strong suction, you can take 2 ml of bone marrow tissue. Then films are prepared immediately by placing the aspirated material on glass side and sucking of the blood which is contaminated. Then air dry, and then films are fixed into the spirit or methyl alcohol, and then you can do staining of the smears by Leishman or Wright stain. So by Leishman or Wright stain, you have to add the stain for 5 minutes, then add buffer for 5 minutes, and then wash with water and dry it and see under high power and then oil immersion lens. Now after the smears are stained, then we can do examination of the bone marrow. So in that we have to see certain points like cellularity, so either normal or hypercellular or hypocellular. So that we can make out by the cavities which are present because of the fat cells. So if the normal cavities are seen, then it is normal. If the cells are more and cavities are less, then it is hypercellular. If the cells are low and cavities are more, then it is hypocellular. Then we can study erythropoietic series, leukopoietic series, then plasma cells which are seen in increased quantity in multiple myeloma, megakaryocytes, if they are increased, then they are seen in thrombocytopenia. Parasites like blood parasites like Plasmodium species or the Leishmania species we can see, and then we can do special staining of the bone marrow examination for identification of iron. We can do it by Prussian blue, or for the acute leukemia we can do special staining like periodic acid shift, peroxidase or Sudan black staining. In this picture we can see all the myelopoietic series like myeloblast, myelocyte, metamyelocytes, band forms, or erythropoietic series like erythroblast, normoblast, reticulocytes, and thrombopoietic series like megakaryoblast, megakaryocyte and the platelets. So in this picture you can see examination of bone marrow. So all the series of cells of the myelopoiesis, erythropoiesis, thrombopoiesis and the blood parasites like microfilaria, plasmodium species or leishmania. Hello students, welcome to this session. So today we are going to discuss about anemia, very common condition in all the population. So we will see what is the definition, different types and then clinical features and which investigations are required for the diagnosis of the anemia. Now let's see one case. A 46 years old female working as a sales representative at esteemed company came to OPD with complaints of breathlessness while climbing steps, while walking fast and palpitation and headache. She also gave history of irregular menstrual cycles with increased bleeding and for longer duration. No history of any addictions. On examination, thin build, afebrile, pulse 88 beats per minute, respiratory rate 18 per minute, blood pressure 110 by 70 millimeter of mercury. Pallor noted +3 grade on palpebral conjunctiva, tongue and nails. Cardiovascular system, respiratory system and per abdomen within normal limits. So looking at the history and examination findings, investigations advised CBC, complete blood cell count, ESR, PBS to know the morphology of the RBCs and other findings. Urine routine, stool routine, iron profile, vitamin B12 study and serum folic acid. The findings of the investigations: CBC hemoglobin 7.8 gram %, that means it is decreased. MCV, MCH and MCHC all are decreased, and RDW red cell diameter width increased. ESR 45 millimeter, that means it is increased, and in peripheral blood smear RBC morphology microcytosis, hypochromia, anisocytosis, that means variation in size of the RBCs, then poikilocytosis, variation in shape of the RBCs. So RBCs, few are like pencil shape, teardrop shape, elongated, oval. Then in urine routine it is within normal limits, and stool routine no parasite seen. So based on these routine findings, what is your diagnosis? So it is anemia. Now patient is having anemia, but which type of anemia? Because according to that we have to give treatment to the patient. So special investigations are done like iron profile. So in that serum iron was decreased, total iron binding capacity increased and percentage saturation decreased, vitamin B12 and folic acid normal. So now our diagnosis is iron deficiency anemia, and now we can treat patient according to the iron deficiency anemia. Now let's study some basics of the anemia. So definition: when the hemoglobin value is low as the extreme normal range of the age and sex of individual, it is called anemia. So clinically patient presents with fatigue, weakness, tiredness, effort intolerance, effort breathlessness, that is dyspnea, faintness, sometimes patient falls, bleeding conditions, headache, palpitation, poor concentration in study or work. So now how to classify anemia? So there are two types of classifications: morphological classification and etiological classification. So first we will see etiological classification, that is based on the reasons. So first reason can be blood loss. So it can be acute or chronic. So if acute blood loss, it can be seen in accident when the blood loss is there, or injury, operation. Then chronic blood loss, so it can be seen in hookworm infection, menstrual bleeding excessively, then bleeding from gums, nose, piles, fissure. So they are in small quantity, but because of the chronic loss you can see anemia, that is decreased hemoglobin concentration. Second reason can be impaired red cell production. So because of the deficiency of the things which are required for formation of hemoglobin, like iron, vitamin B12, folic acid, proteins, so because of deficiency of this, the red cell production is less and then hemoglobin value is less. Then third reason can be the excessive red cell destruction or lysis, that is seen in hemolytic anemia. And the hemolytic anemia, the red cell destruction can be intracorpuscular or extracorpuscular. So that we will see in detail when we will see hemolytic anemia. The second type of classification is morphological classification. So it is based on findings of MCV, MCH, MCHC and RBC morphology in peripheral blood smear. So first type is normocytic normochromic anemia. So in that MCV, MCH, MCHC all are normal. Then second type is microcytic hypochromic anemia. So in that MCV, MCH, MCHC all are decreased, and in PBS we can see smaller size of the RBCs, that is microcytosis, and less concentration of hemoglobin, that means less quantity of red cells, that is redness to the red cells. So it is called hypochromia. And the causes for this condition can be iron deficiency anemia, sickle cell anemia, thalassemia. The third type is macrocytic anemia, when the MCV is more than 96 femtometer and the RBC morphology, they are increase in size in the peripheral blood smear. And the conditions are megaloblastic anemia, pernicious anemia, hemolytic anemia also one condition. So investigations done are two types: routine investigations to know whether anemia is there or not there, and specialized investigations to know which type of anemia. So first, routine investigations. So basic investigations like blood routine, that is HB, CBC, ESR, PCV, peripheral blood smear for RBC morphology and typing of anemia, red cell indices, mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, red cell diameter width, so that you can see in cell counter readings, urine routine for urobilinogen to know hemolytic condition, stool routine, that is parasites can be seen in stool microscopic examination, example hookworm, which causes iron deficiency anemia. Then specialized investigations for typing of anemia. So iron profile for the iron deficiency anemia, thalassemia, hemoglobin electrophoresis, osmotic fragility test, fetal hemoglobin test. For sickle cell anemia, sickling test, hemoglobin electrophoresis. Then for megaloblastic anemia, vitamin B12 and serum folic acid estimation. For pernicious anemia, vitamin B12, folic acid and intrinsic factor investigation. Hemolytic anemia, retic count in peripheral blood smear, normoblast can be seen, and osmotic fragility test. Aplastic anemia, bone marrow examination to rule out aplasia, that is pancytopenia. So these are all specialized investigations for typing of anemia, so that we can give specific treatment to the patient. Let's see first type of the morphological classification, microcytic hypochromic anemia. So it is decreased RBC size, decreased MCV less than 80 femtometer in size, then decreased MCV, decreased hemoglobin, decreased MCH and MCHC, that is hypochromia, and increased pallor of the RBCs in peripheral blood smear is called as microcytic hypochromic anemia. So RBC size is decreased and hemoglobin is decreased. The causes for this is one very common cause is iron deficiency anemia. Then can be genetic defect seen in few children, that is thalassemia, and sometimes anemia of chronic disease like tuberculosis, rheumatoid arthritis. Then in blood picture we can see decreased hemoglobin, decrease or RBC indices like MCV, MCH, MCSC, and in PBS we can see microcytosis and hypochromia. Special investigations done for confirmation. So for iron deficiency anemia we can do iron study, in that serum iron, serum ferritin, percentage saturation and TIBC can be done. And thalassemia we can do osmotic fragility, fetal hemoglobin and confirmatory test, that is hemoglobin electrophoresis. Iron deficiency anemia, the most common type of anemia, it occurs at all ages, especially in females and children. Iron deficiency anemia develop when supply of iron is not sufficient for hemoglobin synthesis, because for hemoglobin iron is required. So causes can be in females, the monthly regular blood loss, that is menstruation, pregnancy, and decreased iron intake in diet, because previously females used to eat after everyone is eaten, so they used to get decreased diet. And in children, decrease iron intake because children are little very choosy, and blood loss can be there because of the parasites like hookworm. Routine investigations like CVC, ESR, PCV, peripheral blood smear can be done, and then special investigations like iron studies for confirmation of iron deficiency anemia, that is serum iron, which is decreased in IDA, then ferritin decreased, TIBC, total iron binding capacity increase in iron deficiency anemia, and percentage saturation is decreased. Peripheral blood smear examination can be done for iron deficiency anemia. So in that we can see blood picture like microcytosis, RBC size decreased, hypochromia, that is pallor of the RBC increased, anisocytosis, that is different size of RBC, few RBCs are smaller in size, middle size, bigger in size. Then poikilocytosis, different shapes of RBCs you can see in this diagram. Few RBCs are elliptical, teardrop, pencil shape. Then occasional normoblast, occasional target cell can be seen, and retic count is slightly raised. So this is blood picture for iron deficiency anemia. Prevention is always better than the treatment. So we can prevent anemia, and the iron deficiency anemia is very common in Indian setup, so we can prevent that by taking diet iron rich food, that is jaggery, green leafy vegetables, dates. Then treatment of acute and chronic blood loss should be done, early medical checkup by doctors, then investigations for diagnosis and typing of anemia should be done, early treatment for prevention of complications of the anemia should be there.
Macrocytic anemia, when the RBC size is increased or MCV is increased, it is more than 100 femtometer. Causes can be megaloblastic anemia, hemolytic anemia, or sometimes it can be aplastic anemia. So in blood picture, in peripheral blood smear, we can see increased RBC size, that is macrocytosis. Then special investigations we can do according to the cause, like megaloblastic anemia we can do vitamin B12 or folic acid estimation. For hemolytic anemia we can do retic count or osmotic fragility test. Megaloblastic anemia, so when macrocytic anemia is because of the vitamin B12 or folic acid or both deficiency, it is called as megaloblastic anemia. The name megaloblastic means mega means more or increased size of the RBC. So etiology can be because of the decreased intake of vitamin B12 or folic acid, like decreased intake of leafy vegetables, or intake is normal but the decreased absorption because of the gastric causes like gastric atrophy, pernicious anemia, or intestinal causes like disease of small intestine like celiac disease or ileitis. So in blood picture in PBS you can see macrocytosis. So in this diagram you can see increased RBC size, the macrocytosis, and because of that there is variation in size, so it is also called as anisocytosis. Then the neutrophil is usually hyper segmented, more than 4 to 5 lobes of the neutrophils, the nucleus, and in MCV of the RBCs increase. Special investigation can be vitamin B12 serum or serum folic acid can be done, or bone marrow examination. In that you can see increased cellularity because of the increased RBC production, and then many megaloblast you can see with Howell-Jolly bodies. So Howell-Jolly body is pink color dot present in the megaloblast in the bone marrow or in the macrocyte in PBS. So it is called Howell-Jolly bodies. It is diagnostic of the megaloblastic anemia. Pernicious anemia, so it is anemia because of the deficiency of vitamin B12. So intake of the vitamin B12 is normal but absorption is less because of the gastric atrophy or gastritis, which results in the macrocytic anemia, that is increased RBC size, and then glossitis, that is infection of the tongue, and nervous development. So it is because of the deficiency of intrinsic factor. So this intrinsic factor is secreted by the stomach cells, and because of the gastritis there will be deficiency of intrinsic factor, and then or maybe antibodies present in gastric juice against the intrinsic factor, and so it decrease vitamin B12 level, and then it causes megaloblastic anemia. So it is megaloblastic anemia due to deficiency of the intrinsic factor which is secreted by the gastric cells. So in blood picture it is similar to megaloblastic anemia, that is macrocytosis, anisocytosis, and in serum vitamin B12 is decreased, and but folic acid may be normal. And when you do serum intrinsic factor, it is decreased, or serum intrinsic factor antibody test is positive. Hemolytic anemia, so it is because of the red cell destruction is increased, that is hemolysis. So this can be because of the intracorpuscular mechanism, that is it is present inside the RBC, like membrane defect you can see in sickle cell anemia, thalassemia, or abnormal hemoglobin can be seen in sickle cell anemia or thalassemia. Then it can be because of the extracorpuscular or extrinsic mechanism, so in that it is drug induced, or it is because of the burns, chemicals, or poisoning like lead poisoning, or it can be seen in newborn because of the Rh incompatibility. So investigations, hemoglobin is decreased, hemoglobin is present in urine, and then we can do antibody test in hemolytic disease of newborn. Sickle cell anemia, as the name suggests, the RBC become sickle in shape or half moon shape because of the abnormal hemoglobin, that is HbS, and in that there is substitution of valine for glutamic acid in 6th position of the beta chain of the hemoglobin. So this is a hereditary disorder, and it is because of the decreased oxygen tension is there because of the abnormal hemoglobin S, and because of that the RBCs become rigid and sickle shape when there is deficiency of oxygen, like at the high altitude, and then RBCs are fragile and they cause hemolysis. The symptoms, the face of the person is changed. It is usually childhood disease, and in that we can see abdominal joint or bone pain, and spleen is enlarged because of the increased hemolysis. So in blood picture you can see sickle shape RBC, sickling test is positive, hemoglobin solubility test is positive, and the confirmatory test for sickle cell anemia is hemoglobin electrophoresis. Thalassemia, it is group of disorders with genetically determined reduction in rate of synthesis of one or more type of normal hemoglobin polypeptide chain, so either alpha or beta chain. So there are two types of thalassemia: alpha thalassemia when there is reduced alpha the type of polypeptide chain, and beta thalassemia when there is reduced beta polypeptide chain. So etiology, it is genetic or hereditary disorder, and in blood picture you can see hemoglobin is very much decreased, less than 6 to 8 gram per deciliter. Then there is microcytosis, that is RBC size is decreased, hypochromia, RBCs are pale, that is hemoglobin concentration is decreased in RBC, and because of the size variation you can see anisocytosis, shape variation you can see poikilocytosis, and there is typically increased target cells. So target cells, they have double red color, so one in the center and one at the periphery, and sometimes basophilic stifling, that is purple color granules can be seen inside the RBCs. Then retic count is increased, and there is the microcytic hypochromic anemia. So all RBC indices like MCV, MCH, MCSC all are decreased, and osmotic fragility test is increased concentration. Special investigations we can do bone marrow examination and hemoglobin electrophoresis for the confirmation of the thalassemia. Aplastic anemia, as the name suggests, there is aplasia, that is all the cells are decreased, and etiology can be because of the long exposure to the chemicals, drugs, x-ray, infection, or overuse of antibiotics, chemotherapy, radiotherapy. So in that there is pancytopenia, that is anemia. In that you can see breathlessness, leukopenia, so more prone to infection, thrombocytopenia, more prone for the bleeding. So investigation, hemoglobin, CBC, ESR increase, then CBC you can see WBC decreased, and in differential count there is different cells, then platelet count decreased. In PBS there is microcytic hypochromic anemia with leukopenia and thrombocytopenia. So picture of pancytopenia, that is all cells are decreased. So confirmatory test for this is bone marrow aspiration. So in that cellularity is decreased, erythropoiesis, myelopoiesis and thrombopoiesis shows megakaryocytes increase, and then bone marrow biopsy can be done for the confirmation after bone marrow aspiration. So in that fatty area is increased and cells are decreased.
Now let's see one case why CBC parameters are so important. So a young boy, he's B chemical, he came to Bombay for job. So in that medical examination done and CBC advised. So he came to Nanavati hospital lab and then CBC is done. So in that the first CBC count, that is the total WBC count, was 74,000 cells per cubic millimeter. Then peripheral blood smear report done, and in that many blast cells seen. So bone marrow aspiration and bone marrow biopsy advised, and it is done. And the person diagnosed as AML, that is acute myeloid leukemia. Then few cycles of chemotherapy given. Then because he was very young, so bone marrow transplantation advised. So he has six brothers, so one brother's bone marrow matched and then transplantation done at Tata hospital. After few months he came to Nanavati hospital again for the CBC investigation, and that time it was a normal report. So because of the CBC, the person got diagnosed AML earlier, and then he got treatment earlier and then early cure. That is why CBC is very important. So in CBC, what are the CBC parameters? So it is hemoglobin, total RBC count, total platelet count, total WBC count, then differential leukocyte counts. In that we can see A granulocytes like lymphocytes, monocytes, and granulocytes like neutrophil, eosinophil and basophil. And RBC indices, in that PCV, MCV, MCH, MCHC and RDW can be seen. So all these parameters we can do manually, but because of the calculations it takes longer time. So nowadays, because of the advanced automated cell counter system, we can do all these parameters within a minute in one aspiration in the cell counter. So definition of leukemia. So this is abnormal proliferation of the hemopoietic cells, that is abnormally hemopoietic cells, that is precursors of the RBCs, WBCs and platelets, that is the immature forms of all these blood cells. They are abnormally increased, and then because of that they infiltrate into the bone marrow, and then the process of differentiation in leukemic cells is often abnormal and is commonly result in immature morphological appearance. So they are also called as blast and the other forms of the immature cells. So that abnormal proliferation of the hemopoietic cells is called as leukemia. Now we will see etiology. So what is the reason for that? So it can be seen because of the alteration of structure of DNA in the nucleus, and then chromosomal abnormalities like very common in leukemia, and then because of the radiation or chemicals like benzene, so people working in benzene factory, or few viruses which are causing this leukemia, and then some genetic factors are there. So these are all the etiological factors which are responsible for the leukemia. Now we will see classification of leukemia. So they are classified as acute and chronic according to the clinical symptoms of acute onset or chronic disease, and then they are divided into myeloid and lymphoid type according to the cell line, that is morphology of the cell line involved in the leukemic process. So leukemia is classified as acute when more than 30% of the bone marrow consists of blast cells, and then it is divided into acute myeloid leukemia or acute lymphoblastic leukemia according to the series of the myeloid or lymphoid series involved. Then chronic, when the less than 30% of the bone marrow consists of blast cells, it is called as chronic leukemia, and again it is divided into chronic myeloid leukemia or chronic lymphoblastic leukemia according to the series of the cells involved. So now acute leukemia is divided into two types, acute myeloid leukemia and acute lymphoblastic leukemia. So now acute myeloid leukemia is divided into 7 types. So they are labeled as M1, M2, M3, M4, M5, M6, M7. So M1 is myeloblastic leukemia without maturation. M2 is myeloblastic leukemia with maturation. So nucleus is matured in the M2 type. Then M3 hypergranular promyeloblastic leukemia. M4 is myelomonocytic leukemia. M5 is monocytic leukemia, then M6 is erythroleukemia, M7 is megakaryocytic leukemia. Then acute lymphoblastic leukemia are of three types: L1, L2, L3. So L1 is small lymphoblast, they are homogeneous, so all are the mostly small lymphoblast. L3 is large homogeneous lymphoblast, and L2 is mixture of, that is heterogeneous, so it consists of small plus large lymphoblast. Now chronic leukemia, so it is chronic myeloid leukemia or chronic lymphoblastic or lymphocytic leukemia. So clinically patient is presenting with acute leukemia. So most common symptoms are anemia, fever, malaise, bleeding, that is hemorrhage, bruising, pateki. So bleeding can be from the gum or from the nose or from the skin. Then less common symptoms are infection of the mouth, pharynx, pain in bone and joints, mainly in childhood, upper respiratory tract infection, mainly in childhood. Now we will see lab diagnosis of leukemia. So investigations can be done. So routine investigation like hemoglobin, CBC, ESR, PBS and platelet count. So in PBS then we can see morphology of the cells. So it is RBC, microcytic anisocytosis, that is variation in size of the cells, poikilocytosis, that is variation in shape of the RBCs, then normoblast, that is nucleated RBC, that is immature form of the RBC is seen, polychromasia, that is purple RBCs, then increased retic count is there. WBC total count is markedly increased, up to 1 to 4 lakhs the cells per cubic millimeter can be there. In differential count, major cells are blast cells, so more than 30%, or mainly cells are blast cells, either myeloblast or lymphoblast according to the acute myeloid or acute lymphoid series. Then platelets are increased, so it is hypercellular response. Then we can do bone marrow for the confirmation. So bone marrow is hypercellular, so all the many cells are there, and then the fatty area is less. Then in acute leukemia, more than 30% myeloblast cells are there. In chronic leukemia, less than 30% blast cells are there. In chronic myeloid leukemia, cells of myelocyte series are increased, and basophilia is also there. Hello students, welcome to this session. So today we are going to study about other hematology blood disorders. So other than anemia, leukemia, so blood disorders are polycythemia, spherocytosis, multiple myeloma, systemic lupus erythematosus, lymphoma, etc. First is polycythemia. So it is disease state in which hematocrit, volume of RBCs in blood is increased, or hemoglobin concentration is increased in the blood. Symptoms are high blood pressure, formation of blood clots, can be headache, vertigo, dizziness, fatigue, tiredness, lack of concentration. Unusual bleeding, nose bleeding, itchiness after exposure to warm water due to histamine and prostaglandin release, numbness, tinglings in body parts, burning pain in hands, feet, reddish bluish discoloration of skin, also called as erythromelalgia. Complications can be because of the blood clots, thrombosis, heart attack, stroke, deep vein thrombosis, Budd-Chiari syndrome, hepatic vein thrombosis, pulmonary embolism. On examination, on physical examination, patient is plethoric, that is red in color, per abdomen, spleen and liver enlarged. Investigations, RBC 8 to 9 million cells per cubic millimeter. WBC and platelets are also increased, ESR decreased, PCV is increased more than 55%. So 70 to 80% is also there. So there are two types, absolute or primary polycythemia vera and relative polycythemia vera. So first, primary can be because of the increase in RBC. So it can be because of overproduction of RBC due to primary process in bone marrow. Myeloproliferatory syndrome, chronic disease, low oxygen levels, malignancy, over transfusion of RBCs. Relative can be decrease in plasma volume, so decrease water loss in dehydration, burns, stress. Secondary polycythemia due to natural or artificial increase in erythropoietin, also called as physiological polycythemia. Conditions altitude related, hypoxia, cyanotic heart disease, sleep apnea, smoking, carbon monoxide poisoning. Iatrogenic causes can be phlebotomy, bloodletting and concentrated blood RBC transfusion. Investigations: RBC 8 to 9 million cells per cubic millimeter, WBC RBC increased, and ESR decreased, PCV increased, serum erythropoietin low. Treatment: phlebotomy, removal of blood from circulation, that is called bloodletting. Drugs can be aspirin, myelosuppressive drugs like hydroxyurea, and oxygen therapy. Spherocytosis, it is a hereditary disorder, that is because of the problems with RBCs. Instead of biconcave disc, RBCs are round like spears, are called spherocytes, and are more fragile than the normal RBCs. Causes: warm autoimmune hemolytic anemia, cold autoimmune hemolytic anemia, paroxysmal cold hemoglobinuria, hemolytic blood transfusion reaction, hemolytic disease of newborn, snake bite, hyposplenism. Pathology: molecular defect in one or more of protein of RBC membrane, so RBC contracts to spear. RBC has high osmotic fragility when placed into water. RBCs are more likely to burst than normal RBC. Symptoms: patient is having anemia, jaundice, enlarged spleen. Blood picture: in PBS, spherical RBCs are many, reticulocyte count is increased, osmotic fragility test, it is increased, serum bilirubin is increased. Multiple myeloma, it is cancer of plasma cells, that is one type of WBC that normally produces antibodies. So risk factors can be obesity, radiation exposure, family history, chemicals, Epstein-Barr virus. Pathology: plasma blast proliferation leads to increased plasma cells, leads to abnormal antibodies deposited in various organs. Signs and symptoms: bone pain, fatigue. Complications can be amyloidosis, kidney disease, bone fracture, infection, anemia, hyperviscosity syndrome, bone lesions, osteoporosis. Investigation: blood, anemia, hemoglobin less than 10 gram%, PBS, rouleau formation of RBC seen, increased calcium more than 11 gram%, increased serum creatinine, urine, Baines-Jones proteins are present, protein electrophoresis of blood and urine, paraprotein, that is M protein band present, quantitative measurement of immunoglobulin A, IgG and IgM increase, beta 2 macroglobulin present, bone marrow biopsy, increased plasma cells more than 10% in the bone marrow, myeloma cells, single nucleus with single nucleolus with vesicular nuclear chromatin and is eccentric and with abundant blue cytoplasm that you can see in this picture. Systemic lupus erythematosus. So it is autoimmune disease in which body's immune system mistakenly attacks healthy tissue in many parts of body. Causes can be genetic, hormonal like estrogen, environmental like female sex hormone, then sunlight, smoking, vitamin D deficiency, infections. In SLE, body's immune system produces antibodies against self proteins in nucleus. Symptoms can be fever, malaise, joint pain, muscle pain, fatigue, chest pain, hair loss, mouth ulcers, face red, rash on cheeks, that is called butterfly rash, photosensitivity, malar roche, that is on cheeks, rash on cheeks. Complications: heart, pericarditis, myocarditis, endocarditis, atherosclerosis. Lungs, pleurisy, pneumonitis, kidney, painless passage of blood or protein in urine, psychiatric disturbances, eyes, dry eye syndrome, Raynaud's phenomenon, fingers turn white or blue on cold. Investigation: blood hemoglobin decrease, WBC decrease with lymphopenia, platelet decreased. ELI cell test can be done. It is ELI cell seen in Buffy coat of patients. In this picture you can see. Then anti-nuclear antibody test positive, anti-DS DNA test by ELISA or immunofluorescence positive, anti-Smith antibody test. Prevention can be lifestyle modifications, avoid sunlight, avoid activities that induce fatigue. So in this picture you can see female with the butterfly rash, that is rash present on the cheeks. Lymphoma, it is group of blood and lymph tumors that develop from lymphocytes. So two types: Hodgkin lymphoma, almost 10% cases, and non-Hodgkin's lymphoma, 90% cases can be seen. Clinically, enlarged lymph nodes, they are painless, fever, sweating at night, weight loss, itching, constantly feeling tired. Risk factors can be Epstein-Barr virus infection, autoimmune disease, AIDS, tobacco smoking. Investigations, lymph node biopsy, blood, bone marrow testing can be done. So in blood, bone marrow, you can see abnormal cells, that is Rein-Sternberg cells seen in lymphoma. Hello students, let's study about coagulation. So coagulation is a mechanism of the hemostatic mechanism, that is to stop the bleeding. Hem means blood and static means to stop. So the clot, which is composed of network of fibrin threads and cells like RBC, WBC and platelets and plasma, adhere to the vascular opening. Therefore it adheres to the opening and then it prevents blood loss. So now what are the steps? So there are mainly 3 steps. So after the damage of the vascular tissue, thromboplastin is released. So thromboplastin converts prothrombin into thrombin, then thrombin converts fibrinogen into fibrin, and then fibrin monomer forms fibrin polymer when they all come together, and then with the cells it forms clots. So all these coagulation factors are in inactive state when it is in the fluids blood, but when the damage to the vessel takes place, the clotting factors, that coagulation factors get activated, and then they convert one inactive factor into the active factor. Now we'll see coagulation factors. So there are total 13 in number. So they are by Roman numbers. So first fibrinogen, second prothrombin, third tissue thromboplastin, fourth calcium, fifth labile factor, sixth name is not given, seventh stable factor, 8 anti-hemophilic factor, 9 Christmas factor, 10 Stewart power factor, 11 plasma thromboplastin antecedent PTA, 12 Haemat factor, and 13 fibrin stabilizing factor, that is FSF. So these are total 13 factors in the coagulation process involved for the clotting of the blood and to stop the bleeding when the blood is oozing from the blood vessel, so that there should not be more blood loss. Now we will see what are the bleeding disorders or hemorrhagic disorders. So they are total divided into 3 types: vascular defect, platelet defect and coagulation factor defect. So because of the vessel defect or platelet defect or coagulation factor defect, there is bleeding continuously and then it causes bleeding disorder. Now we will see few examples of these defects. So vascular defect, it can be acquired. So it can be in infection like bacterial infection, typhoid, tuberculosis, or viral infection like chicken pox, rubella, measles, the pox, or because of the drugs or because of the vitamin C deficiency like scurvy. Then congenital, it can be hereditary hemorrhagic disease. In platelet defect, it can be qualitative or quantitative. So qualitative can be congenital, like platelet disorders seen in congenital disorder like Gleisman's disease, Bernard-Soulier disease, or gray platelet syndrome. Then quantitative, so when the total normal platelet count, that is 1.5 to 4.5 lakhs per cubic millimeter. So if it is less than 1.5 lakh per cubic millimeter, it is called as thrombocytopenia. So causes of thrombocytopenia can be acquired or congenital. So in acquired, it can be because of the drugs like heavy antibiotics or chemotherapy drugs, or chemicals, leukemia like aplastic anemia, AIDS, liver disease, massive blood transfusion, or infection like dengue, P. falciparum infection. Then in congenital, it can be torch group, that is toxoplasma, rubella, cytomegalovirus and herpes or syphilis, and then congenital leukemia. Then increased platelet count is called as thrombocytosis, and it can be seen in infection or it can be seen in chronic myeloid leukemia. Then causes for the coagulation factor defect. So they can be congenital or acquired. So congenital, when the hemophilia A, that is factor 8 deficiency, and hemophilia B when the factor 9 deficiency, or it also called as Christmas disease. Acquired causes can be liver disease, anticoagulant drugs like warfarin, heparin, or massive blood transfusion. Because of that, the blood gets diluted and the platelets or coagulation factors, they become less, and then it causes hemorrhagic disorder or bleeding disorder. Now we will see investigations of the bleeding disorders. So routine investigations can be CBC, and after that you can do bleeding time by capillary method, also called as Duke's method, clotting time by capillary method or venous method, platelet count, and in peripheral blood smear you can see morphology of the platelets and other cells, and tourniquet test. Then special investigations can be prothrombin time, partial thromboplastin time, activated partial thromboplastin time, thrombin time, coagulation factor assay like factor 8, 9 or others, then platelet function test. So you can see morphology of platelets in peripheral blood smear. Then megakaryocytes can be seen in bone marrow aspiration or biopsy, and then platelet aggregation test, platelet adhesion test. So these are all special investigation for the investigation of bleeding disorders. And there can be investigation of fibrinolysis. So these are clot retraction and clot lysis test, fibrinogen assay, and FDP, that is fibrin degradation products. Now the next is the fibrinolysis. It is breaking down of the fibrin clot. So the clot is dissolved in the blood vessel, and then blood flow again starts in the blood vessel. So the mechanism, the fibrin clot, there is plasminogen activator within the clot, so which activates plasminogen into plasmin, and then plasmin converts fibrin into the fibrinogen degradation products. The investigations of the fibrinolysis are clot retraction and clot lysis time, fibrinogen assay, and fibrinogen degradation product assay. So let's see coagulation disorder. So one of that is hemophilia. So it is an inherited genetic disorder in which mechanism to stop bleeding is impaired, so which results in bleeding for longer time after the injury. So there are two types: hemophilia A because of the clotting factor 8 deficiency, hemophilia B because of the clotting factor 9 deficiency. So it is X-linked recessive disorder inherited from one X chromosome of one parent. So females are mostly carriers. So clinically there is mild type when the factor 8 is more than 5%, so it bleeds only after major trauma. Moderate type factor 8 is 1 to 5%, it bleeds only after minor trauma. And moderate factor 8, if it is less than 1%, then it bleeds spontaneously and also associated with the deep bleeding. So clinically, bleeding after injury, dental procedure, surgery, accident, then internal bleeding, joint damage, bleeding into soft tissue, muscle, skin, gums, mouth, stool, urine. So complications are deep bleed in muscles causes swelling, pain, numbness in limb. Joint bleed causes hemarthrosis. Then intracranial bleed causes loss of consciousness, brain damage, death. Investigations: coagulation profile, clotting factor is prolonged, prothrombin time is normal, APTT is increased, clotting factor 8 or 9 low. Treatment: hemophilia A, clotting factor 8 is given, hemophilia B, clotting factor 9 is given. Von Willebrand's disease, it is most common hereditary disorder due to qualitative or quantitative defect in von Willebrand's factor VWF. It is a larger fraction of factor 8, so it is factor 8 VWF complex which circulate in blood. The function of it is coagulation and platelet adhesion. It is synthesized in endothelial cells, megakaryocytes and platelets. So clinically in that disease, the spontaneous bleeding from mucous membranes and from wounds. Types: type 1 most common, mild moderate decrease in von Willebrand factor 50%. Type 2 it is less common, so VWF is near normal. Type 3 it is rare, so VWF is not detectable and low factor 8. In treatment, cryoprecipitate or factor 8 concentrate should be given. Investigation: platelet count normal, platelet aggregation with ristocetin is defective, bleeding time prolonged, plasma VWF factor is reduced and factor 8 is also reduced. Let's see DIC, disseminated intravascular coagulation. So it is thrombohemorrhagic disorder in some systemic diseases. So etiology can be massive tissue injury because of trauma, surgery, infections like gram-negative bacilli, meningococcal infection, widespread endothelial damage that happens in burn. Miscellaneous causes can be snake bite, shock. So here the activation of coagulation is there, then thrombotic phase will be there, then consumption phase, then secondary fibrinolysis, that is FDP, fibrinogen degradation products are formed, then bleeding, then ischemic tissue injury, microangiopathic hemolytic anemia. So clinically patient will be having bleeding and some organ damage, that is kidney or brain. So investigation profile, platelet count is low, PBS shows RBC cystocytes, fragmented RBCs. Then coagulation profile like PT, APTT, TT are prolonged and FDP is raised, that is fibrinogen degradation products raised.
Hello students, welcome to this session. So today we will study blood group. So first, universal safety precautions. So these are a set of infection control practices used to prevent transmission of diseases that can be acquired by contact with blood or body fluids with non-intact skin or mucous membranes. The components are hand hygiene, personal protective equipments, biomedical waste management, injection safety, routine environmental cleaning, disinfection, then spillage cleaning, respiratory hygiene, appropriate handling of the linen. So these are few important components of the precautions. Hello students, welcome to this session. So today we will study blood group. So what is blood group? So they are red cell antigens. So the antigens present on red cell give the blood group characteristics. So this opposite of to that is the antibodies present in serum. So they are called as natural antibodies, and immune antibodies, if they are produced because of the antigen is not present in blood, and if it is introduced into the blood, then it produces antibodies. They are called as immune antibodies. Now we will see types of blood group systems. So there are mainly two types of blood group systems in Indian station. So it is ABO system and RH system. So in ABO system, mainly four types of blood groups are there: A, B, AB and O, according to the antigens and antibodies present, that we will see later on. And the second system is RH system. So RH positive blood is called as when the D antigen is present, and RH negative blood is when the D antigen is absent. So in this chart you can see group, antigens present on RBC and antibodies. So in A group, A antigen is present on RBC and anti-B antibody is present in serum. In B group, B antigen present on RBC and anti-A antibody present in serum. So it is opposite of the antigen, that antibody is present in the serum. So these anti-A and anti-B, they are called as natural antibodies. In AB group, A and B, both antigens present on RBC, so no antibody present in serum. In O group, antigen is not present, either A or B, so anti-A and anti-B, both antibodies are present in serum.
So inheritance of blood group depending on the antigens, so phenotype and possible genotype. So in A group there is AA and A0. O group no antigen, that is 00. B phenotype BO and BB. AB phenotype, that is AB.
Some points about Bombay blood group. So it is discovered by Bhende. So normally H antigen is present. It is seen in saliva, seminal fluid. So it is also called as secretory antigen. So if H antigen is absent, then you will see anti-H antibodies in the blood. So normally it is H antigen present in blood, so no anti-H antibodies are seen. But in O group, if O positive, then the anti-A and anti-B, both antibodies are seen in O group and no antigen. So OH, that is Bombay blood group, anti-A, anti-B and anti-H antibodies are seen because H antigen is not there. So when O group is given to the O patient, but if the patient is Bombay blood group, then this anti-H antibody will react with the H antigen present in the patient and there will be lysis of the blood. So the Bombay blood group patient should get Bombay blood group donor. Now methods of ABO blood grouping. So they are mainly two methods, forward and reverse. So forward is also called as cell grouping and reverse is also called as serum grouping. So in forward or serum grouping, we have to take cell suspension, RBC of the patient, and then we have to add known antiserals. And in serum grouping, you have to take serum of the patient and you have to add known cells of the from the kit. So and then we will see the clumps. And for RH blood grouping, only forward grouping is there, that is cell grouping. Reverse grouping is not there because natural and anti-D antibodies are not there. So now in short, principle of blood grouping is when antigen and antisera, they are mixed together, they forms agglutination or clumps, and then we can decide the blood group. So in short forward method, it can be done on slide or tube method. So you have to take 1 drop of blood and then 1 drop of known anti-sera, that is anti-A, anti-B, and add these two, wait for 2 minutes and see for the clumps. So if the clumps present in anti-A and no clumps seen in anti-B, then it is A group. If clumps present in anti-B and no clumps in anti-A, it is B group. If clumps seen in both the anti-A and anti-B, then it is AB group. And if no clumps seen, it is O group. So O group means it is 0, no antigen. Now in reverse method, you have to take 1 drop of serum and then you have to add 1 drop of known A cells, B cells, and then see for the clumps. If you are taking this in tube method, you have to mix and centrifuge and then you can see clumps. So now here interpretation is opposite. So if you see clumps in A cells, it is B group. If you see clumps in B cells, it is A group. If you see no clumps, then it is AB group. And if you see clumps in both A cells and B cells, it is O group. Now we will see significance of blood group. So significance of blood group, the blood group, everyone should know their blood group, because when in accident or in surgery, when too much blood loss is there, then we need blood. So which blood to be taken from donor, we should know that to prevent the hemolysis of the blood or mismatched blood transfusion. Again in pregnancy also, mother and father blood group should be there, because if mother is negative, if father is positive, then if baby is positive, then that D antigen will cross to the mother through the placenta, and in next pregnancy, because of the anti-D, the immune antibodies are formed, and in next pregnancy D antigen of the fetus will react with the anti-D antibodies and it will cause hemolytic disease of newborn. Again for identity purpose also, for medical legal purpose also, this blood group should be known. Now little bit about Rh antigen. So Rh antigen, it is discovered in rhesus monkey, and when 1 drop of blood is taken, 1 drop of anti-D from the kit and see for the clumps. So if you see clumps, it is Rh positive. If you see no clumps, it is Rh negative. And natural Rh antibodies are not present. They are immune antibodies. When the Rh negative person gets exposed to Rh positive blood, then there is formation of antibodies, and then that is called as Rh antibodies. So it can be seen in mismatched blood transfusion or hemolytic disease of newborn.
Hemolytic disease of newborn. So when Rh negative female marries to Rh positive husband and conceives Rh positive fetus. So Rh positive RBCs of the fetus enter maternal circulation and stimulate Rh negative antibodies in mother. So they are immune antibodies and they can pass through the placental barrier, and then next time when pregnancy is there, they cause hemolysis of fetal RBC. So this is called hemolytic disease of newborn. So manifestations can be abortion, intrauterine death, child born with jaundice, edema, ascites. So prenatal diagnosis, blood grouping of husband and wife, and if Rh negative mother, detection and titration of Rh antibody in maternal blood by ICT, that is indirect Coombs test. Postnatal diagnosis, DCT on the direct Coombs test on infant's blood to detect sensitization of RBC, blood grouping of fetus, then HB, PBS, serum bilirubin, reticulum, and the signs of hemolysis, management, exchange, transfusion. So the significance of cross-matching is to prevent transfusion reactions like hemolytic reactions which occur because of the mismatched blood transfusion. So now types of cross-matching, there are two, major and minor. So in major cross-match, donor cells are mixed with patient serum. So in that, donor's antigen is going to react with the patient's antibody. In minor cross-match, patient cells are mixed with donor's serum. That means patient's antigen will react with the donor's antibody. Now see the steps of cross match. So first we have to take these cells and serum suspension in saline and keep at the room temperature for half an hour. Then these test tubes we have to keep at 37 degrees Celsius for half an hour. Then we can add bovine albumin 22%. and keep test tubes for half an hour in the incubator. Then we can add papain enzyme and then again keep the test tubes in the incubator, and finally we can add Coombs serum, that is anti-human globulin serum, in the test, and then keep that for the half an hour in the incubator. Coombs test. So there are two types, direct and indirect. So direct Coombs test detects antigens on RBC, uses hemolytic disease of newborn and hemolytic anemia and mismatched blood transmission. Indirect Coombs test detect antibodies in plasma or serum. So uses blood grouping to confirm Rh negative group. DU test is done similar to ICT, cross matching using Coombs serum and mismatched blood transmission reaction. And then antibody D titer, when indirect Coombs test positive, titration of antibodies is required. So it is the highest serum dilution which shows agglutination. So significance, rising titer anti-D antibody indicated occurrence of hemolytic disease of newborn. Learning points are selection and screening of donor, collection of blood, anticoagulant blood bank, and storage of blood. Selection and screening of donor. So first, donor's point of view, age should be 18 to 55, ideally 25 to 40 years. Gender, males are preferred. Female in menstruation and pregnancy not accepted. Hemoglobin more than 12.5 gram percent. History of hypertension, diabetes, tuberculosis, heart disease, anemia not accepted. Recipient's point of view, temporary rejection. Donor under treatment of cold, flu, tuberculosis not accepted. Permanent rejection, history of AIDS, hepatitis B, jaundice, blood cancer, bleeding disorders not accepted. History of malaria, syphilis, history of blood transfusion 3 months back, also temporarily rejected.
Blood bank. So first it was ACD, that is acid citrate dextrose. Then it was CPD, that is citrate phosphate dextrose, and now it is used is CPDA, that is citrate phosphate dextrose adenine, or sometimes SAGM, that is saline adenine glucose mannitol. So we'll see functions of each component. So citrate, it acts as a anticoagulant. Phosphate, it acts as a buffer. Dextrose, it gives nourishment to the RBCs to be kept for more days. And mannitol, it is a membrane RBC membrane stabilizing agent. So ACD, blood can be stored up to 21 days. CPD, blood can be stored up to 30 days. CPDA, blood can be stored up to 35 days. And SAGM, blood can be stored up to 42 days. And this SAGM mainly used in a high setup blood banks. Hello students, today we will talk.
Collection of blood procedure. Blood collection in routine hospital practice done in morning time. First, donor should be resting in bleeding chair to make donor comfortable. Donor should be adjusted according to technician who is going to collect blood. Full aseptic precaution should be taken in bleeding room, and donor should be treated as he feels comfortable. Cubital vein of the arm should be collected. Curve for blood pressure instrument should be tied around upper arm, and BP noted, and BP kept at 70 millimeter of mercury so that it obstructs vein and not arteries. Skin should be properly sterilized with spirit swab. Ball is given in donor's fist, and he is asked to do movements of opening and closing his fist regularly. A sharp and clean venous puncture is made so that free flow of blood can be obtained. Donor should be kept engaged to avoid fear. Blood collected in blood bag should be mixed with anticoagulant so that no hemolysis or clotting of the blood. Blood bag weighed on machine. As soon as required quantity of blood is collected, BP cuff is released, blood tube is clamped and needle withdrawn. Firm pressure applied on puncture site with spirit swab. By milking bag, blood contained in rubber tubing is collected in bag, then clip off tube and keep bag in the refrigerator. Let's study blood components in blood bank. Blood components are prepared from whole blood by using large refrigerated centrifuges. The high gravity forces developed in these machines can cause the blood to separate into liquid plasma and its different cellular elements.
For preparation of platelet concentrate, centrifugation is performed at room temperature 20 to 40 degree. For all other blood components, centrifugation is carried out between 1 to 6 degrees Celsius. So from one whole blood, red cells, that is PCV, and platelet-rich plasma can be prepared. Then by hard spin, platelets, and then fresh frozen plasma. And then from fresh frozen plasma, cryoprecipitate can be prepared. Indications of blood components: whole blood for transfusion where the large volume of blood is required, like accidental bleeding or operation. Vaccine volume, chronic anemia. Platelet concentrate, severe thrombocytopenia because of chemotherapy, plasma, falciparum, malaria, dengue fever. Fresh frozen plasma, bleeding patient with multiple coagulation factor deficiency secondary to liver disease. Cryoprecipitate, factor 8 deficiency, factor 13 deficiency in hypofibrogenemia. Albumin, hypovolemic shock, hypoproteinemia. Rh immunoglobulin, Rh negative female to prevent hemolytic disease of newborn. Factors for storage of blood depends on additional glucose and pH of anticoagulants. Correct temperature, it should be maintained at 4 degrees Celsius. Above this temperature, there may be bacterial contamination. Below this temperature, it may be frozen and hemolysis may occur. So storage of blood in blood bank, collected blood is stored at 2 to 8 degrees Celsius in refrigerated with adding anticoagulant. Platelets stored at room temperature with continuous agitation, and then plasma is stored minus 80 to minus 100 degrees Celsius temperature. Blood transfusion procedure. So this is a following point should be noted. Particulars noted on bottles should be tallied with particulars of the patient. Patient should be resting. Blood transfusion should be started in morning. After starting transfusion, first 50 ml should be transfused very slowly. Then rate is adjusted as required. Record pulse, blood pressure, temperature, respiratory rate, and examine chest. Time of starting transfusion should be immediately stopped on occurrence of any transfusion reaction. Maintain urine output chart and color of the urine. Time at which transfusion is completed and amount given should be noted. Following measures should be taken immediately on occurrence of reaction. Transfusion should be stopped immediately and medical officer in charge of blood bank informed. Normal saline or glucose saline should be started through vein on other arm. Samples sent for laboratory for investigations. Leftover blood in bag and blood transfusion set. Post transfusion sample of blood of the patient should be taken. Complications of blood transfusion reactions, that is mismatched blood transfusion reactions, are febrile reaction, allergic reaction, circulatory overload, hemolytic reaction, reactions due to infected blood, thrombophlebitis, air embolism, transmission of diseases like HIV, hepatitis B, malaria, syphilis, transfusion hemosiderosis because of the overload of the blood, complications of massive blood like citrate, potassium toxicity, post-transfusion purpura because of the dilution of the blood. Investigations of blood transfusion reactions. First, detailed history. Second, regrouping of patient and donor's bag. Third, re-cross-matching of pre-transfusion sample of patient and donor's bag. Post-transfusion urine microscopy occur blood test for hematuria. Blood microscopy to see clumps of RBCs, centrifuge and see for hemolysis. Direct Coombs test on patient's blood culture on blood from the bag.
Hope you find this session useful for your understanding and for your exams. Thank you.